For centuries, a sticky resin from poppies decided who might survive the surgeon's knife. Imagine a crowded tent or stone chamber, a patient gagged with fear, friends holding arms and legs, a blade flashing, and a surgeon working as fast as hands can move. There was no machine to make people sleep. Instead, apothecaries and family members turned to one thing above all: opium. Raw poppy latex was scraped from seed pods, dried into a dark gum, then turned into a bitter drink, a tincture known as laudanum, or soaked into sponges that were pressed to a patient's face. That single drug was the tool that dulls the edges of agony, slows a wild body, and sometimes, crucially, keeps a person from dying of shock. You'll see how those preparations were made by hand, how they were given just before the cut, and what patients actually felt. A heavy, dreamy fog that could calm raging pain, but left nausea, confusion, and the risk of slipping too far toward unconsciousness. It didn't erase pain the way modern methods do. It softened and shortened it enough that surgeons could work faster and survival rates improved. Today, patients are made comfortably and precisely unconscious with medicines and monitors. Back then, opium was blunt, unpredictable, and still a lifesaver. Listen closely. This is a story of human ingenuity and danger, of a single plant that bridged a dangerous gap in medical history. Why surgery was so painful before anesthesia. Surgeons had no reliable way to stop pain completely, so most operations had to be done quickly and with as little finesse as possible. Opium, drawn as a sticky latex from poppy seed pods, was one of the few tools available to soften the worst of human agony. People either swallowed raw opium, took it dissolved in alcohol as laudanum, smoked it, or applied crude poultices to wounds. Each method changed how fast and how strongly the drug worked. The strength of the stuff could vary wildly from one batch to another, and that made dosing a gamble. Patients were often prepared for the worst, held down by assistants, wrapped in leather straps, or pressed into a wooden stock while the work began. A single dose might make someone drowsy and blunted at the edges, but it rarely made them numb. Hands clawed, teeth clenched, voices rose and fell. Some drifted in and out of a fog, others stayed fully present under the knife. Nausea and vomiting could flare, and fainting from shock or blood loss sometimes ended the noise, brief relief that the medicine alone could not supply. Timing and uncertainty were constant problems. Opium taken by mouth could take too long to take effect, and smoking it produced a very different, short-lived high. Surgeons feared giving enough to stop pain completely because too much could slow breathing and make the patient worse. That fear meant doses were cautious. The work itself added to the misery. Without drugs to still the muscles, people could thrash or jerk, and cutting through bone or deep tissue was both more brutal and less precise. Even when opium dulled sensations, the tugging, tearing, and pressure of surgery remained vivid. Compared with modern anesthesia, which can reliably block pain, relax muscles, and keep breathing steady under careful observation, opium was blunt and unpredictable. It allowed some patients to tolerate operations that would otherwise have been impossible, and it sometimes reduced immediate suffering enough to save lives. Yet it left many people exposed to agony during the cutting, and it brought its own risks: confusion, breathing trouble, and unreliable comfort. In that harsh context, opium stands out as a practical but limited method, one that eased suffering in part, while underscoring how far medicine had to go to make surgery humane. How opium was used during operations. In hospital wards and on battlefields, surgeons turned to opium as their principal way to blunt suffering when cutting could not be avoided. The substance came from the milky sap of the poppy plant, collected and dried into a sticky mass that could be eaten, boiled into syrups, or dissolved in alcohol to make a tincture known to many as laudanum. Practitioners mixed it with wine, honey, or simple water to mask its bitterness. Sometimes a spoonful before a procedure was the only hope for keeping a patient still long enough to finish the work. Preparation methods varied with place and skill, but the goal was always the same: deliver enough of the drug to dull pain and calm the mind without leaving the person too weak to survive the next hours. Surgeons and their assistants used several routes to give the drug, depending on the setting and how quickly they needed an effect. Oral doses were the most common, swallowed liquids that made people sleepy and slow to react. Cloths soaked in opium mixtures might be held near the nose so the fumes could be inhaled. Poultices pressed to the skin could transfer some of the active substance into the body at the site of the wound. In crowded tents or simple clinics, a patient might also be given opium with alcohol to deepen the stupor. Each method had trade-offs. Drinking worked more reliably than a poultice, but drinking also meant vomiting and choking were real dangers during an operation. The experience for patients was uneven and often terrifying, though not without moments of relief. Many arrived fearful and anxious. A few fell into a heavy, dreamlike sleep that made the surgeon's knife seem distant. Others remained partly conscious, silenced by drowsiness but aware enough to feel pressure, smell burning, or cry out in sudden bursts. Hands and ropes kept limbs from thrashing. Short, skilled operations were possible when opium quieted the nerves enough for the surgeon to work quickly. Long or complicated procedures, however, still demanded speed because opium did not provide steady, controllable unconsciousness. Recovery could be slow. Delirium, nausea, and profound tiredness followed, and some patients never fully regained their previous strength. Compared with modern anesthesia, opium was blunt and unpredictable. Today's anesthetics are designed to render a person fully unaware while protecting breathing and vital functions. Back then, surgeons had only a single, powerful plant drug that dulled pain and soothed shock, but could not guarantee safety or full insensibility. Still, opium made a practical difference. It reduced the immediate terror and shock of cutting, lowered the chances that a patient would die from uncontrolled fear and bleeding, and allowed more ambitious surgical work than would have been possible with no drug at all. The relief it provided was real, even if crude, and it stands as a bridge between pure endurance and the careful, controlled pain relief medicine uses today. Did opium really help patients survive surgery? When surgeons reached for opium before cutting, they were buying time and easing terror rather than erasing pain completely. Opium is the dried, sticky juice of the poppy seed pod, and it was turned into many forms people could swallow, smoke, or mix into wine. A common preparation was laudanum, an opium tincture dissolved in alcohol so that a patient could be given a few spoonfuls. Sometimes powders or pills were used, and at times poultices containing opium were placed near wounds. Those preparations delivered alkaloids like morphine and codeine into the body, which dulled sensations, produced drowsiness, and calmed frantic hearts and minds. Before anesthetics that brought unconsciousness, surgeons relied on speed, muscle, and whatever drugs could blunt the body's violent response to injury. Operations were done quickly. Patients were held down. The aim was to shorten agony and to prevent the body from slipping into shock, a collapse of circulation and breathing that could follow extreme pain. Opium could lessen that fight-or-flight surge by slowing breathing and heart rate and by calming anxiety, which sometimes made the difference between surviving the immediate ordeal and dying on the table. It did not stop the cutting or the burning of cautery, but it often kept a struggling patient from hyperventilating and bleeding more heavily. The experience for the patient could be harsh, yet not entirely unbearable. A person given a strong dose might drift into a heavy sleep, swallow thin liquid, and then wake later with a vague memory of the incision, or wake with a focused memory of pain at certain points. Others remained semi-conscious, groggy, and disconnected, hearing voices and sensation without the sharp edge of panic. Assistance was simple and practical. Friends or assistants held limbs, a gag prevented biting, and the surgeon worked faster because the patient was less likely to thrash. That partial relief mattered. Surgical mortality was influenced by how well a patient tolerated the immediate trauma, and opium's calming effect often reduced deaths from shock and uncontrolled bleeding, even though it could not prevent infection or later complications. There were clear dangers and limits. Dosage varied wildly because preparations were unstandardized and potency depended on the source. Overdose could depress breathing severely, especially when combined with alcohol and laudanum, and that posed a direct threat during and after surgery. Addiction could develop when opium was used repeatedly for ongoing pain, turning a life-saving comfort into a chronic problem. And most important, opium could not sterilize a wound or stop infection, so a patient who survived the cut might still die days later from pus and fever. Compared with modern anesthesia, the difference is striking and simple. Today, an anesthetist controls consciousness, pain, breathing, and blood pressure with precise drugs and monitoring, so that surgery is painless and the body's responses are managed. In the older practice, a single drug like opium attempted to blunt pain and dread, but did not provide unconsciousness or comprehensive control. The contrast explains why early surgeons emphasized speed and post-operative care. Opium made the immediate danger easier to endure, while modern anesthesia makes the whole process safer and more humane. Concrete cases from surgical practice illustrate both the benefit and the risk. A wounded person about to have an arm removed might be given laudanum and tied to a board. The surgeon's swift work, aided by the drug's calming effect, could keep the patient breathing until bandages closed the wound. Conversely, a patient given too much opium could become dangerously slow to breathe and require frantic resuscitation that was often impossible in that era. The truth is balanced. Opium did help many patients survive the most perilous moments of surgery by reducing shock and terror, but it was an imperfect tool, sometimes life-saving in the short term and sometimes producing other harms in the long term. By the time a knife met skin before modern anesthetics, surgery was a race against time and human limits. A surgeon moved with practiced speed while helpers held a struggling body still. Opium, gathered as a sticky latex from the poppy, dried, then dissolved into wine or spirit to make a tincture called laudanum, was the single most relied on painkiller. Given by mouth or soaked into a cloth, it dulled the edge of pain, brought a heavy sleepiness or haze, calmed crying and panic, and in some cases helped patients survive the shock of the wound. It did not make people truly unconscious like modern medicine can. Doses were uncertain, responses varied, and dangers from infection and bleeding remained. Still, in an age without masks, monitors, or controlled gases, opium often meant the difference between surviving the operation or not. Imagine the patient's view: terror, the press of hands, a bitter draft swallowed, then a slow drift into a quieter, clouded world where pain did not shout as loudly. It was rough and risky, but it was real help, rooted in ancient knowledge of the poppy and refined into tinctures that healers carried across towns and continents. Key points: surgery relied on speed and force. Opium prepared as tincture or draft was the core pain relief. Effects were sedating and variable, never a true sleep like today. Risks from infection, overdose, and insufficient pain control were common. If this story spoke to you, leave a comment with your questions or a story you want explored next, and click like or subscribe to support more history told in human terms. Next time, we'll follow the path from those smoky bedside tinctures to the discovery of modern anesthetics, and how that leap changed the surgeon's world and the patient's fate. Thank you for watching. Stay curious and compassionate.